It's so cold in UP. It's so very, very cold.
Hello, Arunda.
Hello, Bhaskar.
Namaskar, Barua sir.
Namaskar.
Namaskar, sir.
Hi, Barwa. How are
Namaskar.
you?
I'm good. I'm good.
Namaste, ma'am. आप muted हैं.
हाँ जी, very good evening to all. Yeah.
Namaste.
Bhavna, can we
Bhavna,
start this?
please start.
Yeah, please start it. Yeah.
Bhavna,
Yes, ma'am, we are live now.
please start. You have to start the screen share. Please start introducing.
A very good evening, respected dignitaries. Today we are gathered here for Searchlight episode number 8, an initiative by CSR Society, all about ectopic pregnancy.
Oh,
Supported
you
by
forgot to change the topic. The topic is polycystic ovarian disease. All about polycystic ovarian syndrome.
okay.
This heading is wrong.
Yeah.
I request Dr. Sujayshri ma'am to please introduce Dr. Asha ma'am.
A very warm welcome to all the faculty and delegates who logged in today. Can we have Dr. Asha ma'am CV, please?
Bhavna,
There is some issue, ma'am.
listen, you please make me co-host and I will share it.
So firstly, before introducing Asha ma'am, I would like to make a mention that madam had a personal event at home. We were not sure we would be able to conduct the event today, but in spite all hurdles, we're here today. So we have to admire Asha ma'am. She's here in spite of everything. So to introduce ma'am, she is the director of SMSA Hospital in Raipur. She's also the medical director of Cancer Prevention and Relief Society. She has been the chairman of Mission Pink Health IMA Raipur and the executive member of ISCCP. Academically, madam is the instructor in FSCC OB course. She's also trained people in colposcopy from AV School of Colposcopy, Chennai. Her fields of interest are saving the uterus, fetal medicine, obstetric and gynec ultrasound, critical care, preventive oncology, and colposcopy. So I request ma'am to please take over the session and proceed.
Thank you, Dr. Sujay. Thanks a lot. And we start with invoking the blessings of the divine before we actually start the program, because it's just the divine that helps us in getting anything done. So would you please play the... We can't hear anything. Have you started the volume? You have to start the audio when you're sharing the screen. Actually, we couldn't hear any of the prayers. I'll just say them aloud. Om Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarva Karyeshu Sarvada Om Asato Ma Sadagamaya Tamaso Mam Jyotirgamaya Mrityor Mam Amritam Gamaya Om Shanti Shanti Shanti. With pranams to all, I welcome all the faculty and from Allahabad, Delhi, Ambala, Amritsar, Anand, Aurangabad, Aleppi and Angamali societies, and our chief guest, Dr. Uday Thanawala sir, our guests of honor, Dr. Bhaskar Pal and Dr. Arun Barua, the convener, Dr. Sujayshri, and our respected speakers, Dr. Chaitanya Ganpule and Dr. Basab Mukherjee, the respected chairpersons, Dr. Shubha Pandey, Dr. Jitendra Patel, Dr. Radhika, Dr. Poonam, Dr. Amrit Palkor, Dr. Amita Suneja ma'am, also all our panelists, Dr. Aparna, Dr. Uma Jaiswal, Dr. Thingu Thomas Koshi, Dr. Shraddha Paritkar, Dr. Sugandha Chopra, Dr. Rajesh Prajapati, Dr. Bindu S, and Dr. Meera Lattakia. I also welcome our experts, Dr. Aparna Rao, Dr. Lalitambika Karnakaran ma'am, and Dr. G.C. George Kurian. I welcome all the listeners and viewers on this program. I hope we are able to put our searchlight on a topic that is PCOS. We are able to share the knowledge of PCOS with everyone and update ourselves because all our programs are focused on guidelines. And now we have the ESHRI 2023 guidelines on which we'll be basing our panel. I would like to invite Dr. Uday Thanawala sir, the past ICOG chairperson, for his words of blessing. He is a consultant obstetrician and gynecologist at Navi Mumbai. He is the immediate past chairman, ICOG, vice president, Federation of Obstetrics and Gynec Societies of India in the year 2015. He is also the treasurer of PCOS Society of India, chairperson, Medical Disorders of Pregnancy Committee of FOXI, founder secretary and past president of Navi Mumbai Obstetric Gynec Society, joint secretary of FOXI in the year 2005, and has a gold medal in the FCPS exams, Sir G.M. Masani prizes for best research paper in 81-82, Dr. D.K. Datta Award for
Thank
best
you,
journal
Asha.
publication in FOXI. So welcome,
Thank you,
sir.
Asha.
It's
Thank
an
you very
honor to
much.
have you here.
Thank you very much, and thank you so much
Please
for
stop
inviting me.
sharing.
I didn't want you to read all those dates because it makes me feel very, very ancient, when you read those dates of what has happened. So anyway, it's great to be on this program, which is called as Searchlight, and it's good to focus on one particular topic and bring out everything you can in that particular topic. It's a good learning experience for practitioners and students alike. PCOS is a subject which is so varied and changing. Every day there is something new added to PCOS. So it is very important that we people who are in clinical practice keep up to date on the PCOS topic. And this webinar will definitely help them to do it because you have divided it into excellent portions. First is diagnosing PCOS. Today we see so many ultrasound reports coming to us and saying, oh, like ovaries appear polycystic. And immediately the woman is brought here, even adolescent girls are brought with their mothers and they say, oh, abhi kya karne ka uska? So unless you know how to tackle these things, unless you know what is correct, what is incorrect, it is up to us gynecologists, and we have to even tell the radiologist not to give this diagnosis as a very loosely done diagnosis, which it is done, because adolescent PCOS is something totally different. The management is totally different. PCOS itself the patient requires a lot of counseling, whether it is nutrition, whether it is exercise, whether it is lifestyle change and drugs. And so many misconceptions are there in the doctor's mind and in the patient's mind. Because if a woman is seeking fertility and you put her on OC pills, well, that's not fair. So we need to diagnose each patient individually and treat them individually when it comes to PCOS. And I'm so glad to see the panel which you're having, which is covering everything, including menopausal PCOS. So thank you so much, Asha, for having me here. We've got stalwarts here like Bhaskar and everybody else who is here. And wish you all the best for this program. Wish you all the best for Searchlight. And I hope everybody attending this really does a good job. And let me just add that we have a PCOS Society of India where we deal only with PCOS. And those who are interested, please log on to the PCOS Society of India website. You'll get a lot of information there, a lot of videos, lectures, etc. there. And we have one annual conference every year. This year it's in the month of June, the third weekend of June in Bombay. So keep a watch out for that. It's a good program which talks basically only about PCOS, and you'll benefit a lot from it. Thank you so much, Asha, for having me, and very nice of you to do this. Please carry on the good work. Thank you.
Thank you so much, sir. And I almost became a member of that PCOS society, and the payment link didn't work, and I didn't become a member. I wrote a mail and I got a mail back. Thank you, sir. Thank you. So thanks for those very kind words. And now I would like to introduce Dr. Bhaskar, sir. The guests I have today actually don't need any introduction in Foxy, but still it's a privilege to remind ourselves of all they have achieved. So before I actually talk about Bhaskar, sir, he is going for president this year, President Foxy. So I want everybody to remember that. He is a senior consultant gynecologist at Apollo Multispecialty Hospital, Kolkata, chair of the endoscopy committee, SAFOG, chair AICC RCOG 21 to 23, immediate past president IAG, Foxy representative to SAFOG 21 to 23, chair and organizing committee of the excellent AICOG 2023.
That should be enough.
Kolkata.
That should be enough. Dr. Asha, that should be enough. That should
Thank
be
you,
enough.
sir. And we seek your blessings to this webinar.
Thank you very much. At the outset, Dr. Asha Jain, thank you very much for inviting me. I'm deeply honored. It's great to be among friends like Uday, Arun, Dr. Arun Madhav Barua, my elder brother. We go, all of us, Uday, myself, Arunda, we go back a long way. And great to be among youngsters who make you feel younger. Dr. Sujay Sri, Dr. Chaitanya, my younger brother Basab. As Uday pointed out, I think polycystic ovarian syndrome is a very important topic because on one hand, sometimes we underdiagnose it, sometimes we overdiagnose it. It's a complete two ends of the spectrum. Sometimes we do not intervene too soon. Sometimes we do interventions that are not needed. Sometimes with fertility, we intervene too soon or do not intervene at all. The biggest problem is again with diagnosis, because the problem is there are too many radiologists in the country who diagnose PCOS when they should be diagnosing only PCO or PCOM, that is polycystic ovarian morphology. I'm sure that this webinar will go ahead and clear a lot of doubts. Personally, while I'm a big fan of physical meetings because I love meeting friends and sharing a laugh and a cup of tea together, but webinars have their own appeal. They're much more equitable, they're much more accessible, and I think this is our biggest takeaway point or the beneficial point that we've taken from the COVID pandemic. So I can see that we have two great speakers in Dr. Chaitanya Ganpule and Dr. Bashar Mukherjee, and a wonderful panel moderated by Dr. Asha Jain. It's my regards to Dr. Shubha Pandey, Dr. Jitendra Patel, Dr. Radhika from Delhi, Dr. Poonam Lumba Madam, Dr. Amrit Pal Kaur Dhillon, whom I've seen after a very, very long time, Dr. Amita Suneja, Dr. Aparna, Dr. Lalitambika Madam, Dr. G.C. Kurian, Dr. Umay Jaiswal, Dr. Koshi, Dr. Shraddha from Aurangabad, Dr. Sugandha, Dr. Prajapati from Anand, Dr. Bindu, and Dr. Meera from Allahabad. So I'm sure you'll have a very fruitful meeting. And the name Searchlight is great because academics are supposed to shed some light on a particular topic. and clear confusion, take the darkness away, darkness of confusion, of ignorance away. So I wish you all the best. And lastly, I wish Dr. Asha Jain all the best for her future endeavor. Last time she narrowly missed being a committee chairperson, and we need to make sure that she becomes one this time. Thank you.
Thank you, sir. Thanks a lot, Basab sir. Bhaskar sir, that was very kind of you. And please share Barua sir's CV, please. Dr. Barua sir is, I think, everything in the Northeast. Anything you want to do, anyone you want to contact, it's always speak to Barua sir. So he has made a very, very small CV, I think suited to online meetings. He's a consultant at Apollo Fertility Guwahati, chairperson Northeast IAG, founder chairperson Northeast ISAR, past president Dibrugarh, and senior VP IMA Assam State Branch, Vice President East Sovsi, and active Rotarian since 25 years. Wish to see you as DG someday, sir. So with this, I invite sir for his blessings.
Thank you so much, Asha. Actually, I'm in a very dark mode because I'm traveling, and probably the lights around me may not be representing my name. And the Searchlite, the name itself also is related to my name because we also try to set light across the society, and I'm sure the endeavor that you are trying to make will have a great impact on everyone, both seniors and juniors, because knowledge keeps on changing and we need to keep ourselves up and about. Everyone has said their words, so I would just like to say all these webinars really keep us updated, because once we are out of the track, really we will not be able to offer the women the best we should always be. So whatever learning we have, it may not be 100%, but even if it is 20% or 30%, if we start putting it into our day-to-day clinical practice, I think we all will be a great practitioner, and at the end of the day, our women concerned will have a great service from all of us. With these few words, the topic itself is great, and I'm requesting you to be a member of the PCOS Society. That itself actually dissects the subject threadbare. And before I leave with a small sentence, I must add that insulin resistance, which has been not a part of PCOS, but we Indians always need to look at it from a different angle. So for us, insulin resistance, I see at the core center of looking at a PCOS when we speak of the Indian PCOS in context. So with these few words, thank you so much for inviting me. And I'm sure we are going to have a great time in next 2 hours, the great deliberations, and I'm going to become richer with few scientific information from both great speakers that we have in the lineup. Thank you so much, Asha. All the best for your all future endeavors.
Thank you, sir. Thank you. And you will be glad to know that the 2023 guidelines do include insulin resistance.
Yes.
So it's no more just an Indian PCOS. It is included everywhere in the international evidence-based guidelines for assessment of PCOS. So it's there now. So thank you, sir. Thanks a lot, all the dignitaries, Dr. Uday sir, Dr. Bhaskar, Dr. Arun sir, for being here and for blessing this webinar. I hope everyone becomes a member of PCOS Society. And with this, we will like to start the scientific session. Dr. Chaitanya has kindly logged in much earlier. So I would like to introduce my convener, Dr. Sujayshri, who's done all the hard work in this meeting. She's consultant obstetrician and lab surgeon, Seshadri Hospital Palakol and Seshadri Hospital Mallikapuram. She is the founder secretary of Bhimavaram Obstetric Gynec Society, secretary IMA Palakol, and her interests are laparoscopy and infertility. She's presented many papers, organizing secretary of GOSA 2016 and 18, does a lot of awareness programs. She did a very beautiful dance in AICOG this year. So welcome, Dr. Sujaya. Thank you for all the hard work you've put in.
Thank you for those kind words, ma'am. Thank you.
May I have Chaitanya sir's CV, please? No, sorry. The chairperson's CV. The chairperson's CV. Yes. Sujay, you want to take over for a bit?
Sure, ma'am. So I would like to introduce the chairperson for this session, Dr. Shubha Pandey. She is the head obstetrics of gynecological department in Kamala Nehru Memorial Hospital, Prayagraj. She is also the president for the Obstetrics and Gynecological Society of Prayagraj. Madam is a renowned professional who has experience of almost 40 years in the field of obstetrics and gynecology. She has had special contribution in the field of infertility, high-risk pregnancy, cancer screening programs, and geriatric care. She's a teacher and trainer of DNB and DGO students. She's also an examiner of DNB and non-DGO. Ma'am, I welcome you to today's session, ma'am. Can we have the other
Thank you.
CV? I would like to introduce Dr. Radhika, who's the chairperson for today's session. Madam is a certified level 2 trainer for guideline development, national coordinator for the clinical research FOXY. She's also been a representative in international network program. She's a member of the Geneva Foundation for Medical Education and Research, Cochrane collaboration, also for the South Asian Cochrane Network and Campbell collaboration. She has been a recipient of ICOG Visiting Professor Award in 2019, Foxy Korean Award in 2019, Foxy Best Paper Prize in 2016, WHO Fellow Advanced Course on Monitoring and Evaluation Innovations in a Dynamic Health System Environment. She has also been an expert reviewer for the Cochrane collaboration. Madam has almost 75 publications to her name in both international and national journals. She has also edited 3 books. Ma'am, it's my privilege to invite you to today's session. I request you to please introduce the speaker for today.
Thank you so much, Dr. Sujaya. So I'm happy to introduce Dr. Chaitanya Ganapule. There are some, I can't read the first 2 lines.
Yes, ma'am.
He's the director, he's the director of the Pearl Women Hospital and Yash IVF Pune, director of Noble Yash IVF, Satara Yash IVF, recipient of Times Health Icon 2020. He's been invited faculty and publication in national and international journals. He's written chapters in Jeff Coates' textbook of gynecology, that is amazing, and Foxy Focus and others. So, and he's also the chairperson of the Endocrinology Committee, Foxy 2024-26, certified in IVF from London, diploma in gynec endoscopy from France and Germany. He's the chairperson of the Midlife Committee, EMOGS, National Coordinator for Endocrinology Committee 2022-23. So that's truly huge lot of credits. Dr. Ganapule, it's my proud privilege to invite you and to be able to introduce you to you today. So welcome to you.
Thank you so much, Radhika ma'am, for that kind introduction. And at the outset, I would like to thank Dr. Asha Jain, madam, for giving me an opportunity to be here today. And I'm going to discuss something about assessment in PCOS. I would also like to thank Uday sir, Bhaskar sir, and Arun sir for being here today and blessing the occasion. I'll just start sharing my screen. Give me a minute. So there are quite a few guidelines which have been published worldwide on PCOS in 2018. IFRE has now come up with the PCOS guidelines in 2023. But the Indian scenario or the Indian context does change a little bit. And that is the reason why last year when Dr. Rishikesh Pai sir was the president of Foxy, we have come up with a GCPR on PCOS with the help of the Endocrinology Committee Foxy and the chairperson chairman at that time, Dr. Rakhi Singh, and Basab sir, and a few others from the Foxy who have contributed to this GCPR. And we have come up with these guidelines which are pertaining to the Indian scenario. And that's exactly what I'm going to discuss today with you all. So I'm going to go through my presentation with the introduction, then a little bit about Indian context, then the different types of phenotypes, and then the assessment with the history and the clinical assessment, then the risk factor assessment, then the diagnostic criteria which will be used for diagnosis of PCOS, and what all things we would be doing when we are assessing the women of all different age groups with PCOS, and then finally investigations and the differential diagnosis. So as you all know that PCOS is a common endocrinological problem that affects women of all reproductive ages, right from adolescence to the reproductive age group to the perimenopausal age group. The overall prevalence of PCOS ranges from 5 to 13% if I consider all the age groups together. And the prevalence of infertility in women with PCOS varies between 70 to 80%. And therefore, it becomes a very important factor which is contributing to the fertility problems or issues in women, PCOS as such. But when it comes to the Indian context, there are certain things which we need to take into account. Like the prevalence of PCOS in India is close to 12%. The prevalence of infertility in women with PCOS in India is a bit higher as compared to the global scenario, which hovers around 80 to 85%. Indian women with PCOS have a higher degree of hirsutism, infertility, and acne. Very important to note, they experience lower birth rates following IVF treatment. Indian women have high prevalence of insulin resistance, as Dr. Arun sir just mentioned in his speech, and metabolic syndrome compared to BMI matched PCOS women of other ethnic group. So there are certain subtle changes or differences between PCOS when it comes to the global scenario and when it comes to the Indian context. As we all know, there are 4 different phenotypes of PCOS that are now identified: type A, B, C, and D. Type A is characterized by presence of hyperandrogenism, chronic anovulation, and polycystic ovaries. Type B is associated with hyperandrogenism and chronic anovulation. Type C, hyperandrogenism and polycystic ovaries. And type D, chronic anovulation and polycystic ovaries. However, hyperandrogenemia remains the hallmark of polycystic ovarian syndrome. Now, when we are trying to assess the woman with PCOS, we usually start with the history and the clinical assessment. So in the history, ovulatory dysfunction is assessed by taking menstrual history first and then noting presence of any irregularity in the menstrual cycle. Now, a comprehensive and detailed history and clinical examination should be completed to assess the symptoms and signs of clinical hyperandrogenism, that is hirsutism, acne, and alopecia. Psychological impact of hyperandrogenism is very important, is immense, and it should be kept in mind, and history should be asked to rule out clinical depression if any. Now, detailed history of previous treatments should be noted. Now, if she has taken cosmetic treatments in the past, that tells us about the severity of the hyperandrogenism which she has, and that is why it's important for us to know the history of previous treatments. Now, to understand whether she is undergoing any psychological depression, we can use something called as patient health questionnaire 9 scoring system. Now, it's a scoring system which has been devised to know whether she is likely to have a depression or not. And if the scoring system tells us that she is suffering from depression, then it would be a right decision to refer her to a psychologist, or if needed, even a psychiatrist, so that her depression is taken care of. There is something which we should not be neglected at all, and which should be emphasized whenever we are assessing a woman who is likely to have PCOS or is diagnosed previously with PCOS. Now, once we have done the history and clinical assessment, the second aspect which comes to us is the risk factor assessment. Now, the risk factors could be in the form of clinical symptoms, or they could be in the form of clinical characteristics. So what are the clinical symptoms that may point towards presence of polycystic ovarian syndrome in that particular woman? So any pubertal deviations, whether she has had an early menarche or whether she has had a late menarche, could have an implication of in PCOS. Then disturbances in the periodicity or the timing of the menstrual cycle. So if they are delayed, if they are if she is bleeding for quite a long time, so all these disturbances could point towards presence of PCOS. Then early acne or presence of hirsutism. Now persistent severe acne or hirsutism which has been there with her for more than 2 years or so. Frequent relapses of acne or acne in the facial V line, that is about that we call it as jawline. So if she's having acne around the jawline, that again becomes a risk factor for the presence of PCOS. We should inquire about the recent weight gain, particularly around the abdomen, which may point out towards presence of PCOS. Whether she is having a sedentary lifestyle, again an important factor, because that's going to add up to her weight, add up to her overall risk of PCOS. And then the family history of diabetes, because that might point out towards presence of insulin resistance, and then that could lead to polycystic ovarian syndrome. PCOS is linked genetically, and therefore a family history of PCOS again becomes important to assess the risk factors in women for PCOS. When it comes to clinical characteristics, what all things we should look for? Dyslipidemia, wherein we have to go for elevated serum total cholesterol levels, triglycerides, and LDL-C levels. Presence of polycystic ovarian morphology on ultrasound is again a risk factor for PCOS. Then high BMI and acanthosis nigricans and abdominal obesity. Again, so whenever the Indian woman who presents with any of these symptoms or signs, it should be considered at risk of developing PCOS. Now, if we have identified her at risk of developing PCOS, then she should be monitored at regular intervals. And if there are more than 2 risk factors that are present, then she should be investigated further to rule out presence of PCOS. That is how the risk factor assessment is going to help us whenever she presents to us. So what are the diagnostic criteria that we are going to use for the diagnosis of PCOS? Now, there are various criteria which have been put forth, like the one by NICHD, the Rotterdam criteria in 2003, and then the Androgen Excess PCOS Society in the year 2009. However, Rotterdam criteria is the most commonly used, meeting 2 of the 3 criteria. So which are these 3 criteria? Clinical hyperandrogenism, presence of clinical hyperandrogenism or presence of biochemical hyperandrogenism, oligomenorrhea, less than 6 to 9 menses per year or oligoovulation, and presence of polycystic ovarian morphology on ultrasound, wherein we have got now the things have changed a little bit. Now we say that the antral follicle should be more than 20 in each of the ovaries. So if 2 criteria are evident, then there is no need to confirm the 3rd criterion. But for diagnosis, we need to have 2 out of these 3 criteria. Only then we can diagnose her of having PCOS. So let's go into a little bit detail about the diagnostic criteria. Irregular cycle and ovulatory dysfunction. If she is having a cycle which is less than 21 days or more than 45 days, or if she gets less than 8 cycles per year, or any one instance where she has got her periods or she has prolonged her periods for more than 90 days, then we consider that as irregular cycle or ovulatory dysfunction. When it comes to clinical hyperandrogenism, for hirsutism, the visual scales are preferred, and the most commonly used one is the modified Farman-Galloway score. Now, when the score is less than 4, we say it's mild hirsutism. Between 4 and 7, it's a moderate hirsutism, and if it is more than or equal to 8, it is severe hirsutism. Acne, we use Indian Acne Association scoring system to grade the severity of the acne. Again, here you can see that it is graded as mild, moderate, or severe, depending upon presence of or predominance of the comedones, papules, and the nodules. So presence of how many comedones, how many papules, we categorize them as mild, moderate, and severe. Inquire about the cosmetic treatment. Again, we have discussed this point for these issues, as it may suggest severity of the disease. When it comes to biochemical hyperandrogenism, serum total testosterone levels are checked, free testosterone levels are checked, and then a free androgen index is calculated. Now, if androgen levels are very high or significantly raised, then consider other conditions for hyperandrogenemia, like tumors producing androgens. Ultrasound and polycystic ovarian morphology. How do we correlate them? A transvaginal ultrasound is preferred if she is sexually active and it is acceptable to the individual. It is very important for us to take a consent of her before doing a transvaginal sonography, and that is where it says that acceptability of the individual for performing TVS is important. Follicle number per ovary, as I said, it's been changed now. It's more than 20 and or an ovarian volume of more than or equal to 10 ml on either ovaries, ensuring that there is no corpora lutea, cysts or dominant follicles that are present. Transabdominal sonography can be done in women who don't allow us to do a transvaginal ultrasound, and a threshold for PCOM could be the ovarian volume of more than 10 ml if we are doing a abdominal sonography instead of a transvaginal sonography. What about AMH? When should I be using AMH as for the diagnosis of polycystic ovaries syndrome? If there is clinical or biochemical hyperandrogenemia with irregular menstruation, there is no need for AMH assessment. However, if one of the criteria is absent, then serum AMH levels could be utilized for the diagnosis of PCOS in adults. The serum AMH level cutoff which we have proposed in the GCPR is more than 3.2 nanograms per ml because it exhibits high sensitivity and specificity in identifying PCOM regardless of the age and the phenotype of the woman. Now, there are certain things which needs to be done in all the women with PCOS, irrespective of the age group, number one, and irrespective of whether she is desirous of fertility or not. So what are these things? Clinical assessment should be done in all women, irrespective of her presenting complaint. Now, follow-up should be done at an interval of 6 months if she is found to be at high risk of PCOS and 1 year in low-risk women. What all things we look for when she visits us for the first time? Weight is noted, BMI is noted, waist to hip ratio is calculated, blood pressure noted. For hirsutism, we use modified Farman-Galloway scoring system. For acne, as I said, Indian Acne Association score. Alopecia, we use the Ludwig's scale. Then look for presence of acanthosis nigricans. Burke scale is preferred to grade acanthosis nigricans. Then cardiovascular risk assessment should be done. Sorry for the spell mistake. Mental health assessment is very, very important. And again, as I said in the past, patient healthcare questionnaire 9 scoring for presence of depression helps a lot. And in case we find that she is having a depression, timely referral to a psychologist or a psychiatrist helps a lot in her management. What investigations we should be doing to assess the polycystic ovaries? So the investigations are done for 2 reasons. Number one, to confirm the diagnosis of PCOS, to rule out other common differential diagnoses which are there, and to assess the complications which are associated with PCOS. So what are the investigations that we do to confirm the diagnosis and rule out common differential diagnosis? We do serum T3, T4, TSH because we want to rule out presence of thyroid disorders which may mimic clinically with the clinical symptoms of PCOS. Then serum prolactin level is done to rule out presence of hyperprolactinemia. Then FSH and LH levels are done on day 2 or day 3 to diagnose PCOS. LH levels are high and FSH levels are low. I mean in the normal range, but the LH levels are usually high in women with PCOS. As I said, AMH can be done or used if hyperandrogenemia is missing and we are suspecting PCOS. Total testosterone or free androgen index if clinical symptoms and signs are suggestive of hyperandrogenism are absent. Ultrasound to be done for the presence of PCOM. If clinically indicated, then only do an androgen profile or a dexamethasone suppression test based on how high the androgen levels are and what you are suspecting. Well, to assess the complications of PCOS, what all things we should be doing? In all patients of PCOS, one should go ahead and do an oral glucose tolerance test. It's a 75 gram OGTT. Then if OGTT is not available, we should do a fasting blood sugar level and an HbA1c because insulin resistance is a very important factor in the pathophysiology of polycystic ovarian syndrome. And in Indian scenario or Indian context, we have a lot more insulin resistance as compared to the global scenario. Fasting serum lipid profile should be done. Now, if required, based on the clinical assessment, liver function tests, ultrasound to assess the fatty liver. Now, all this is related to the metabolic syndrome. I think someone would be covering the metabolic syndrome in the talks after me. So I'm not going to go into the details of that. And then the sleep study should be done in women who have got sleep apnea. TVS to assess the endometrial thickness if she has got AUB, because it's an anovulatory kind of scenario or the scene which is there, and therefore an unopposed estrogen action can lead to endometrial hyperplasia. And that's the reason why TVS should be done to assess the endometrial thickness. So what differential diagnosis do we have in PCOS? Depends upon the symptoms. For example, if she comes with anovulation, that's irregular menstruation or amenorrhea. Now, it could be pregnancy, it could be hypothalamic amenorrhea, it could be pituitary amenorrhea, it could be hyperprolactinemia, which is related to the irregularity in the cycles, and ovarian origin of the irregularity in the cycles. Now, these should be ruled out with the help of tests, like if we are suspecting pregnancy, do a pregnancy test or a serum beta HCG levels. Hypothalamic, do FSH LH estradiol levels. Pituitary, again FSH LH levels, or imaging studies if we are suspecting a pituitary tumor. Hyperprolactinemia, serum prolactin levels, again MRI brain to rule out presence of pituitary adenoma. Similarly for ovarian and thyroid disorders, which we have already discussed. Then features suggestive of hyperandrogenemia, which could be precocious puberty, hirsutism due to other causes than PCOS, like non-classical adrenal hyperplasia or Cushing's syndrome, androgen secreting syndrome. So we have got tests for each one of them. Like for NCAH, we have 17-hydroxyprogesterone, which should be done early in the morning before 8 a.m. For Cushing syndrome, we do 24-hour urinary collection for urinary free cortisol. Then androgen secreting tumors, total testosterone level, they say if it is more than 200, it is suggestive of androgen secreting tumors, which could be of ovarian or adrenal origin. So this is how the differential diagnosis of polycystic ovarian syndrome should be done as a part of the assessment of the polycystic ovarian syndrome. I'm not going to cover the management aspect of it because Dr. Basab sir is going to cover the management of PCOS. So friends, PCOS is a common endocrinological disorder affecting women of all ages. Early diagnosis and management would help to reduce the complications of PCOS and improve the outcomes. Indian scenario or context is a bit different as compared to the global scenario, and therefore let's start using this GCPR as our guideline for our Thank you so much for your patient hearing.
Thank you so much, Dr. Chaitanya. And over to the chairpersons, please.
Can I ask one question? Can I ask one question to Satenya?
Yes, sir.
Yeah. What test for insulin resistance you recommend for in our settings? Because normally we do not go for fasting or postprandial insulin, right?
Right.
So what would be your recommendation to have a general knowledge that this patient has got insulin resistance?
So insulin to glucose ratio is what usually we recommend. Otherwise, we are not recommending any other test as such.
What we have enough evidence in the literature to prove that 2-hour GTT test, which is more than 140, is a surrogate for insulin resistance.
Yes.
What do you take about this? What is your take on this particular statement?
So that is what we say, that 75 gram OGTT is a good test to know presence of insulin resistance.
Because that gives us much more information than going for the high-end insulin test, which even doesn't give us the same value, even if we repeat it on 2 occasions, right? So, yeah, okay.
So that
was an excellent talk.
Yeah. Thank you, sir.
That was an excellent talk.
Actually, it was a very comprehensive and interesting talk, and so complete that I don't think any more questions are needed. We've all benefited from it. Thank you.
Thank you, Shobha ma'am.
May I just add a comment to that, Dr. Chaitanya?
Absolutely.
Dr. Asha, with
Absolutely,
your
Radhika.
permission?
Yeah,
Yes,
So,
ma'am, please.
yeah, so it was a very interesting, elaborate, and I think, what should I say, a basic as well as an advanced talk. It really completely covered the entire topic. But my thing is about the lean PCOS. Now there is a lot of talk and there is a lot of literature available with respect to diagnosis and treatment of the obese PCOS. But our problem in clinical practice continues to be the challenges about the lean PCOS. So, would you like to, highlight a few important translational points, Dr. Chaitanya?
So when it comes to obese PCOS, we know that there is somewhere a real association between the weight and the presence of PCOS. The severity could be reduced by asking her to reduce the weight, which is not the case in lean PCOS. So lean PCOS management perspective, Basap sir is going to cover that. But lean PCOS, it becomes more difficult for us to manage as compared to the obese PCOS.
And also for the diagnosis, because
Yes.
BMI is considered a high risk factor.
Yeah.
So here is one situation which, could be somewhat challenging.
Correct. So many a times we always keep in mind that obesity, she might have PCOS, but if she's lean, we many a times tend to forget that even lean women can have PCOS, and we should have the clinical symptoms should arise that suspicion in our mind. So therefore the diagnosis could be a bit delayed if she is lean as compared to the ones who are obese.
Right. Thank you so much.
Thank you.
Thank you, Dr. Chaitanya. And thank you, Radhika ma'am and Shubha ma'am. Having you people as chairpersons and all our guests still listening in. I'm really very honored. Thank you, Barua sir, for those comments. And if you're going to be there, we'll be really happy. So,
thank you, Dr.
may I
Asha.
have the...
I just wish to thank you, Dr. Asha, and the entire team for calling us here, having us over. It's been a pleasure and an honor to be in this meeting today. Thank you so much.
Thank you, ma'am.
Very
you
much
so much.
honored to have you.
Thank you so much, Asha madam, and all the very best for your future endeavors. Thank you,
sir.
Chairperson,
Thank you.
for giving expert comments.
Okay.
CV of the chairpersons, please.
Good evening, Basap sir.
Hi, Chaitanya. Hello.
Bhavna, why is this so black? I don't understand. We have our respected chairpersons for the second session. Dr. Poonam Lamba, ma'am. Everybody knows, ma'am. She's an infertility specialist, Lumba Hospital and IVF Center at Ambala. She does infertility, ART, ultrasound, endoscopy, and she has her interest in PCOS, RPL, has been an attendee and faculty at many conferences, and she has the first IVF ART center in Haryana in 2003. She was trained in Cleveland Clinic in US, trained in Harvard in advanced ultrasound fetal medicine, advanced laparoscopic training at Kiel, Germany, and she has held very, very many positions. Now, may I have the second chairperson, please? Welcome, Poonam ma'am. We have Amrit ma'am, who has kindly consented to be here, though she was on leave and she's not, I think, in India, but welcome, ma'am. She's an MBBS MD FI Surgery, Professor and Head, Department of Gynae, Government Medical College, Amritsar. She's the President of Amritsar Gynec Society, Vice President NIGF, Organizing Secretary of North Zone Yuva Foxy 2013. And she's done extensive work in microsurgery, delivered many guest lectures, and has been a faculty in many places, presented more than 30 papers, has many awards, and her areas of interest are high-risk pregnancy, reproductive endocrinology, and contraception. So, next, please. We also have Dr. Amita Sunija ma'am, who has kindly consented to be with us this evening. She's a professor at the University College of Medical Sciences and GTB Hospital. Her areas of interest are cancer prevention and treatment. She's the President, Association of Obstetricians of Delhi, Head, Obstetric Gynae, Faculty of Medical Sciences, University of Delhi, past Chairperson, Oncology Committee, AOGD, past President, Narchi Delhi, 2014 to 16, past Organizing Secretary, World Congress, Nachi. She has a WHO fellowship in gynec oncology in Texas in 1996. She is the recipient of Best Doctor Award, Teacher of Teachers, many awards, more than 100 publications and guest lectures. She's also edited 3 books. Respected chairpersons, welcome to this webinar. I thank you all for being here, and I request you to take over to introduce our chairperson and the topic. Our speaker and the topic.
Yeah, thank you, Dr. Asha. I can't see my other co-chairpersons. They are here.
Yeah, I'm here.
Very much here,
Doctor,
ma'am.
Yeah.
okay. So, very good evening and welcome to a very interesting session, that is management of PCOS, which is very enigmatic disease, and there's so many aspects to it. There's so much of this is a syndrome. So every syndrome, depending upon what syndrome the patient is having, you have to individualize the treatment. And to deal with it, we have none other than Dr. Basha Mukherjee. And now I request Dr. Lamba to formally introduce Dr. Mukherjee.
Yeah, good evening, everyone. Dr. Basa will be here to all of us. I will just, I'm trying to read the CV.
So the Poonam, it is okay. It's all
Oh,
right.
it's okay. I have read it.
Yeah,
No,
actually,
he's a
okay.
well-known,
Yeah,
reproductive
actually,
endocrinologist in Bengal.
I have to zoom it,
Yeah,
to
doesn't
read
matter.
it.
I will say it extempore.
Yeah. So,
Yeah.
Basa, we are very familiar with your knowledge and your talents, and you are a very superhuman being. So, let's start with the topic itself. Thank
Yeah,
you for joining us.
he is a foxy man and has been the vice president foxy and so many important posts he has held. He has been the past president of Kolkata Society, Bengal Society, and many Yuva Foxy conferences. He was the active participant and an active organizer rather. So, sir, I was reading even in the Google about you. We have never met. So the very good feedback from the Google and your as a doctor, as a person, and your competence. So we are here to listen to you. Thank you.
Thank you. Thank you. Yeah. Can you see my screen? First question.
Yes.
And you can hear me. Thank you very much. A pleasure to be here under the invitation of Dr. Asha Jain. Dr. Asha, friend for a very long time, a wonderful president of Raipur OBGYN Society, and we wish her the best in all her endeavors in Foxy and other organizations in the future. Dr. Chaitanya did a wonderful job of introducing you to diagnosis of polycystic ovary. That's where it starts, and that's where the first discussion comes, whether this is PCO or not. Only after you label a woman as PCO or you give her that possibly she is polycystic ovary, then does the management part come. So over the next 12 to 15 minutes, maybe, I would take you through some of the aspects of the modern management of polycystic ovary, the way it stands today. And Dr. Radhika brought up some very nice points about the lean PCOS, how to manage it, and still the dilemmas which exist, which again, some of the points which we can touch. So the sections in this talk would be 3, and they're usually all adopted from the International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovary 2013. So people who had visited ESHRE earlier this year in Paris would know that it was a wonderful conference, and there were a lot of discussions, and this was one of the main lot of areas, lot of discussion on polycystic ovary. And the sections which we would be covering here would be lifestyle modification, the non-fertility concerns, and the fertility concerns. That's a convenient way of just compartmentalizing the two different aspects of PCO which we normally deal with. Of course, there is the psychological aspects of polycystic ovary, which is the least spoken about and the least addressed. But I think that's something also during this discussion we'll bring up. And I think all of us need to be very much aware that a woman who has difficulty in losing weight needs to have some empathy always, and you just cannot accuse her that she's lying or she's cheating in her food habits. So lifestyle interventions, we know and we have grown up, and it has been ingrained in us that whenever a woman with polycystic ovary come, with metabolic syndrome come, with some diabetes come, you have to discuss lifestyle interventions, because they are the first line of management before your medication and before any surgical intervention takes place. And we also know that exercise is of different kinds, and you have to have generally exercise which causes sweating. It has to be for a significant amount of time, at least 150 minutes, possibly even more, if you have to have a weight loss or weight maintenance. And also a diet combination works better than exercise alone. So it's something very important that we always discuss. Often in clinic, we see that even after a lot of discussion and a lot of stress, people find it difficult to lose weight, or they lose very little weight, which it doesn't exactly help them in their clinical situation. But nevertheless, I think it is something imperative that we take that extra minute to discuss about some dietary modifications and exercise. If you think you're not having enough of time, or you do not have the expertise to do so, then she has to be referred to a dietitian or a physiotherapist or some sort of an exercise instructor who will help her with losing weight. Sometimes they may need professional help. Verbal tonic doesn't always help. So don't always assume that your communication skills are superior and you'll be able to do the trick. Sometimes she may need professional help, and you need to guide her in the proper direction where she will get that help. So healthcare professionals should be aware that lifestyle management is a core focus of polycystic ovary management. And so whatever you write on your prescription, I think it's so important that lifestyle modification or lifestyle intervention has to be somewhere, and you need to mean it. So just not writing that is not enough. Just talking to them is not enough. You have to show her a direction, that somewhere where she will get possibly that extra help. Again, you may not have a 1400 calorie diet on the tip of your fingers, but you still have to help her to lose weight. You need to get her some calorie restriction depending on her lifestyle, on her height, on her existing weight. And those are some things which do not come just naturally. She may need some other professional help. So there are benefits of a healthier lifestyle, even in the absence of weight loss. So even if she doesn't feel weight loss, you have some sort of toning up and some sort of cardiovascular benefits, which would help her in the long run, even if the polycystic ovary is not under control. There's another important aspect here, as I said in the beginning, about the psychological aspect of the weight stigma, which is there when a woman is there. So you can't keep on calling her fat. You can't keep on calling him ugly. You can't keep on using words which are detrimental. Now, we have to be very careful, because that may have a lot of psychological impact on her. And also we have to understand, for adolescent PCOS, even the acne, even the hirsuts have a very integral effect on her well-being and on the way she presents to the world. Because for an adolescent girl in the 15 to 25 age group, how she looks is a very important part of her entire well-being and how she exists. So lifestyle interventions in those who are not overweight, now comes to Dr. Radhika's point of the lean PCOS. In the adolescent and at key life, the focus should be on healthy lifestyle and prevention of weight gain. So sometimes we also talk about people who have a sonography diagnosis of polycystic ovary appearance, but does not have irregular periods, does not have signs of hyperandrogenism. So what do you do with them? Do you need to treat them with metformin? Do you need to do anything? And this is where it comes just to talk about a healthy lifestyle and the prevention of excess weight gain. gain. So that is the minimum intervention which you can say, which is generally, you can say, is universal for almost anybody. But for a person who has an ultrasound diagnosis of polycystic ovary, yes, done by a good person, but no other features, so you can't label her as PCO. But you need to have some sort of a prevention strategy so that she doesn't gain weight in the long run and have other problems. Insulin resistance is something, again, Dr. Arun Madhupurva brought this point up. We keep on discussing about it in various discussions in polycystic ovary, whether it's a talk, whether it's a panel, which one to do, fasting insulin, peeping insulin. Again, as Chaitanya said, glucose is to insulin. But generally, it has been said the clinically available insulin assays are of limited clinical relevance and should not be used in routine care. So that comes from Eshere. There's no exact one which is the best. And as Dr. Arun said, that you can do a GTT to find out about how, whether she's got a metabolic syndrome sort of a picture, whether she's got postprandial hyperglycemia, which would give you an idea that she needs some dietary restrictions and that needs to be addressed. So behavioral support could include goal setting, problem solving, self-monitoring and reviewing, or SMART goals. So we have a wonderful Foxy president, Dr. Jaydeep Tank, who keeps on talking about directives and measurable outcomes. That's a very common term which we use in public health systems. So here also specific, measurable, achievable, realistic, and timely interventions, which again, easy to say, difficult to do, but yet we need to stress on them. Now coming to the other part of management, the non-fertility part and the fertility part. So over the next 10 minutes, let us take you through the part of the managing polycystic ovary. What we've discussed, again, all of us know this, but just to reiterate a few points so that so it helps us in our clinical decision making. To share decision making between the patient and the parents or guardians, if the patient is a child, even if the patient is not a child, we know how the Indian setting, the family is a very integral part of the discussion, especially if it's an unmarried girl, especially she's in her late teens. There are concerns about marriage, there are concerns about childbearing. And so definitely the parents would come up with these questions when they're coming up, either in the first diagnosis of polycystic ovary or when they're fed up of having multiple cycles of oral contraceptives where the cycles are regular on pills and irregular off pills, and how to do, how long to carry on, and all those questions. So the healthcare professional has to be there in the shared decision making. I think the important point which we would like to stress, and which a lot of us do, is that it's not a one-off thing, just pop in a pill and forget about it. So it's not those flu or it's not like an infectious disease where it gets solved with a course of antibiotics. It's something which would need long-term care. So same for endometriosis, same for polycystic ovary. You have to stress on the long-term care. That is not something which will need repeated visits and regular follow-ups. So even if she changes 5 doctors and 6 doctors, more or less the treatment would be the same, and she will just get frustrated at the end of it, and it will not help her if she, unless she have a pattern of what the treatment protocol would be. So an individual's characteristics, preferences, and values must be elicited and considered while recommending any intervention alone or in combination. The most common is oral contraceptive pills or hormones. A lot of people are hesitant to giving hormones. Some people even start with just progestogens. They think they consider PCO as an estrogen excess ailment, which is correct in a way. So the just a progestogen can give you your periods intermittently, but the OCP advantage comes with decreasing the androgen levels, increasing SHBG, and several other advantages which COCPs have over progestogens alone in a case of polycystic ovary. So the combined oral contraceptive pills could be recommended in the reproductive age adults for PCO, for the management of hirsutism and or irregular menstrual cycles, something which we commonly do in our clinical practice. The COCP could be considered in adolescents at risk or with a clear diagnosis of PCO for management of hirsutism or irregular COCs. So this is something which we would do. So sometimes weight loss also helps in regularizing cycles. Again, easy to do, difficult always, not always easy, but sometimes weight loss, very characteristically said, 5% of your body weight is something which will make a difference. But again, that may be too much for some people. But at the same time, that's always worth trying before the medication part comes in the picture. So which OCP to give, which is good? So we know classically we would like to stick to drospirenone or cyproterone because we know that those are the two which work well in a polycystic setting. So usually if the obesity is on the most, if it's the obesity which you need to control or you want to have a more weight neutral pill, then it would be the drospirenone. If it's the hyperandrogenic effects, so more of the hirsuts and the acne that you are addressing, then you would like to tilt towards the cyproterone. But here they said that there's no clinical advantage of using a more than 30 versus a less than 30 pill. This is when they were comparing ethinyl estradiol to different types in treating hirsutism in adults with PCO. So there's some thought that if you give a higher estrogen dose, you'll have an increased SHBG, which will bring down the androgen levels further, the free androgens, but that isn't exactly the case in some clinical trials. The 35 microgram ethinyl estradiol, which is the one which has the cyproterone along with it, should be considered as a second line of therapy. This is the ESHRE recommendations over the COCPs, balancing benefits and adverse effects, including venous thromboembolic risks. I think we discussed this in several of our talks and several discussions, academic discussions in the COCPs, that when we're taking a history of thromboembolic, venous thromboembolism, either personally or in the family, needs to be elicited because that is something which is important. Progesterone only oral contraceptives, we know there are a few now. There used to be only desogestrel, now there is drospirenone also there. So that can be considered for endometrial protection based on the general population guidelines and acknowledging that the evidence in women with PCO is limited. So you can use progesterone maybe once a month, maybe once in 45 days, maybe once in 2 months. Not 2 months, usually we say 8 cycles at least in a year to have some reasonable endometrial protection. And there you can have progesterone instead of giving OCPs. Coming to metformin, what about metformin? Metformin alone can be considered in adults with PCO and a BMI of more than 25 for anthropometric and metabolic outcomes, including insulin resistance, glucose, and lipid profiles. So as we know that this, as it was already discussed by our chairperson, that PCO is a syndrome. It's much more than limited to the gynecology perspective. It includes a lot of reproductive endocrinology. And so you need to do more checks than just the gynecology system. So you have to look at the glucose metabolism, the lipid metabolism, the obesity part of it, the OSA part of it, and the cardiovascular part of it, along with other things. So metformin alone could be considered in adolescents at risk of or with PCO for cycle regulation, acknowledging limited evidence. So you have two aspects of PCO. One is in the adolescents for cycle regulation, and one is later during the fertility enhancement. So metformin alone may be considered in adolescents, adults with PCO and BMI less than 25, acknowledging limited evidence. This is where, as Dr. Radhika was mentioning, the lean PCOs come in. Can you give metformin for lean PCOS? Yes, you can give with limited evidence. So the most of the evidence in metformin is for overweight and obese individuals of PCO, but less evidence is there for lean PCO. But it's not that you cannot give it or you will not give it. You will still give it, but possibly at a lower dose, and possibly it may. And we don't have much of evidence to say that it works in those settings. So starting at a low dose, around 500, you increment 1 to 2 weekly, and then go up to a maximum of 2 grams in adolescents and 2.5 grams in adults. We all know how difficult it is often to tolerate, but usually that step-up thing is what helps a lot of people, minimizes the GI side effects, and they're usually self-limiting. And it's problem, the low vitamin B12 is something which needs to be kept in mind. So you can give her supplements, or we can check vitamin B12, better to possibly give supplements. Metformin and COCPs, well, yes, they could be used in the management of hirsutism. Sometimes metformin, sometimes PCO, the COCPs alone will be helpful, but sometimes metformin and combined oral contraceptive pills can be given in a combination, and they may be most beneficial in a setting where the BMI is more than 30. So you have two different ways of controlling that. And also if a woman has diabetic risk factors or impaired glucose tolerance, or it is in a part of a high risk ethnic group, then you would give us possibly in a Indian setting. What about anti-obesity medication? And we'll come to bariatric surgery in a minute. Can they be used? Of course, they can be used, but at the same time, they have to be added along with active lifestyle intervention, and they can be used for as in any obese population setting. Anti-androgens. So what are the anti-androgenic? So we know that a lot of the hirsutism would be controlled if you give a ethanol estradiol cyproterone combination for 6 months. So that would change a lot of the facial hair and the acne. It usually works well, but sometimes you would like to give a little bit more, and we'll be coming to that in a minute. So in combination with effective contraception, anti-androgens can be considered to treat hirsutism with PCO if there is a suboptimal response after a minimum of 6 months of COCP. So you give her 6 months of combined oral contraceptive pills, generally with a cyproterone, and if it still there is response is poor, and you've done all the checking, as Dr. Chaitanya said, you've done your testosterone, you've ruled out ovarian tumors, you've ruled out adrenal tumors as a source of your androgen excess, and you think it's only PCO that is causing this androgen excess, then you may add something more, and that is when anti-androgens may come into the picture. So it could be considered to treat hirsutism in the presence of another effective form of contraception, because you don't want a woman to get pregnant on the anti-androgen. So here are the different anti-androgens which we use. Spironolactone is very commonly used, of 25 to 100, one of the commonest, but a weak anti-androgen, lower risk of side effects. Cyproterone not used in isolation. It's used with as a COCP, and there's an increased risk, including for meningioma. Finasteride also we use in our clinical practice, but we have to be careful as there's an increased risk of liver toxicity. And flutamide, bicalutamide, I don't use personally. They also have an increased risk of severe liver toxicity and has to be kept in mind. Coming to inositols. So that's one of the flavor of the last few years. I think like the dydrogesterone wave, which we are still going through. We were going through a myoinositol and dechirioinositol wave maybe 5-6 years ago, and there was not one company who was not having a product of their own. So inositol, and initially there were ISHRA guidance was quite harsh on inositol, and they said that there's no evidence, there's nothing to be used. Please don't consider it or use it only as an experimental drug or in a research setting. But in the recent guideline in 2023, they have been a little bit more soft on that. So inositol in any form could be considered in women with PCO, noting limited harm, potential for improvement in metabolic measures, yet with limited clinical benefits, including in ovulation, hirsutism, or weight. A lot of our clinicians in our different seminars and conferences which we go claim to have a lot of personal experience using inositols, and a lot of people are very happy using them, both individually or in a combination with metformin. But unless you publish your data and unless you have it all recorded, there's not much of personal experience doesn't much count in clinical practice. Metformin should be used over inositol for hirsutism and central adiposity, noting that metformin has more side effects than inositol. Specific types, doses, or combinations of inositol cannot currently be recommended in adults or adolescents with PCO due to a lack of quality evidence. So whether you want to give it with both the ones, the Chiro and Mayo, or you want to give Mayo and metformin, or you want to give it in with something else, some other combinations which a lot of people have, there's not much of evidence to back anything. Coming a little bit to bariatric surgery. So what about bariatric surgery? Can it help? Yes, it can help. Definitely it helps in weight loss. We know that there's a sharp loss of weight after many different types of bariatric surgery, which comes almost immediately. And then there is a gradual weight gain or plateau till sometimes in a few years, people generally gain back the weight which they lose in the first few months. But at the same time, in a case of a setting in PCO, we understand that women should be counseled that the rapid return to fertility is expected in a few months, but they need to have some effective contraception which keeps them protected, especially an intrauterine device possibly, because the hormonal also tablets, you will have if it's a bypass, you'll have the dumping effect and all. So even when pregnancy is desired, contraception should be continued at least till a year, and after a year she can plan, because till then the weight will settle down, and then if she plans before that and it comes suddenly, you have a chance of FGR, SGA, prematurity, and other problems. Shifting focus to the fertility issues, we'll just handle a little bit of this before we end. We've already taken some time. So, preconception, a polycystic ovary woman should be counseled on the adverse impact of excess weight on clinical pregnancy, miscarriage, and live birth rates following infertility
Dr.
treatment.
Basab, may I interrupt you for a minute?
Yes, please.
Our panelists have mostly not joined, so you can actually take your time. Let us at least cover the subject. I'm getting messages that, I'm unable to join. I'm unable to join. So
no problem. No
you
problem.
can take your time comfortably.
No problem. Thank you. Fine. So fertility issues in PCO. So we're managing. So we are in the discussion of managing PCO, and we initially started with lifestyle management issues. Then we went to the non-fertility issues, where we touched on different aspects with the medication there. And now we're coming to the fertility issues. And whenever there's fertility plan, the first thing is preconception. So preconception care is of immense importance, and we understand that there is different focuses and thrust given to preconception care, both in FOGSI over years. There's even a GCPR. I remember coming in preconception year. I think it was Dr. Nandita in her year had a preconception care GCPR, and that's some guidance that this is a very important time where we have a lot of optimization of health to be done, and it becomes more important in a polycystic ovary setting. So if a PCO woman is planning pregnancy, you need to have her weight, blood pressure, her lifestyle changes, smoking, alcohol, nutrition status, folate supplementation, all that checked, and all that advice have been given before they plan. Of course, to add exercise, sleep, mental, emotional, sexual health, all to be optimized ideally. So if she's on any medical treatment for any existing disease, that comorbidity, any existing, that has to be optimized. So sugars need to be corrected, blood pressure has to be under control, epilepsy has to be sorted. So all those things are there before she plans a child. And in a polycystic ovary setting, it becomes all the more important. So a reproductive life plan, age-appropriate education, and optimizing reproductive health is recommended both in adolescents and PCO and women with PCO, including healthy lifestyle, prevention of excess weight gain, and optimizing preconception risk factors. So even as an adolescent, again, you won't be telling them that lose weight, you'll get pregnant faster when you get married. That it sounds awkward and sounds at least very chauvinistic, I think, at that point. So you don't talk about that. But at the same time, you say that possibly in a better interest of future health, it may be a good idea to to lose weight. So a lot of people who keep on saying that I only get periods when I have medicines, and when I stop medicines, I don't have periods. You can ask them, how much of weight have you lost in this time? And you say, I haven't lost a kg, I've gained one. Then from what my BMI of 31 was, then you say that explains it all. Because once you start medication, a lot of people will say, when will I stop it? How long will I take it? You say you'll stop taking it when you lose 5% of your weight. If you can just say that, then that makes it as clear as daylight that I need to take it for a fairly degree of time. I may stop it after 6 months, see what's happening, but repeatedly having it again and again is maybe needed at some point of time. So chronic conditions, diabetes, blood pressure, anxiety, depression, other mental health conditions should be optimally managed, and women should be counseled regarding the risk of adverse pregnancy outcomes in a PCO setting if it's not, especially not under control. So fertility issues, letrozole as the first line of pharmacological treatment. This is what ESHRE has been pushing. The other organizations haven't been so outright or forthwith with saying that letrozole should be the first line of treatment. But ESHRE and the ASRM, I thought the last, because this was the guideline with the ASRM also in partnership, they have said that letrozole should be the first line of pharmacological treatment, not for every fertility patient, for a fertility in the setting of a polycystic ovary. And when there is no other infertility factors, of course. So you have ruled that out, the male factors and the tubal factors and other things, and you think that this could be the main reason why she is subfertile, then possibly letrozole over clomiphene would be possibly the first line. Metformin could be used alone or with PCO or with no other factors, but it works better if you're giving it with with ovulation induction. So no other infertility factors to improve clinical pregnancy and live birth rates. Very seldom do we give metformin alone to PCO, but you can give it, especially if it's a newly married, they're a little restless. You can try with 6 months of metformin alone with folic acid, of course, see what works, and then you can add your ovulation induction agents if it doesn't work, if the cycles are not regulated and things like that. But there's a scope of trying. And CC could be used in preference to metformin in women with PCO with anovulatory infertility. So, of course, if you have started with metformin, your second line would be clomiphene with metformin or letrozole with metformin, and then to see whether that improves your ovulation, clinical pregnancy, live birth weights. CC combined with metformin could be used rather than CC alone in PCO setting. And I think a lot of us do that in our clinical practice. Sometimes we add metformin, we add myoinositol. Sometimes we're quite desperate. We add a course of vitamin D also, because a lot of these PCO are vitamin D deficient. So that's something which your management, you just add a course of vitamin D, you check vitamin D and then give. So that's there. With anovulatory and no other infertility factors like to improve, oops. So would like to improve clinical pregnancy and live birth rates. So that's there. Fertility, here we are. So letrozole should be used rather than clomiphene in women with PCO with anovulatory infertility, no other infertility factors to improve in ovulation, clinical pregnancy, and the live birth rates. So other things, the last things about fertility issues is gonadotropins could be a second line of pharmacological therapy for women with PCO who are anovulatory and infertile with no other infertility factors and who have failed the first line oral ovulation induction. So once you are done with your letrozole, again, you can't give it a cycle after cycle after cycle after cycle. We so much see it in our clinical practice. You really need to go through the old files and see how many doctors have started the same way. And you can't start from where they started. You have to start where they ended so that you can take the discussion, take the thing forward. Because we have seen, all of us have seen in our clinical practice, people taking letrozole or clomiphene for month after month without any supervision and without any guidance. So that's not in the best interest. So no other fertility factors who have failed the first line of ovulation induction, that you can bring gonadotropins. And again, we all have to we have to think about multiple pregnancy. You have to think about ovarian hyperstimulation, and that's again a different discussion. I personally am not a fertility expert, so I would love somebody else to hear from there. But a low dose gonadotropin protocol should be used to optimize the chance of monofollicular growth and minimize multiple pregnancy. So whenever you're giving gonadotropin, even with CC, you have more multiple pregnancy, but still here you can have more. So live birth, clinical pregnancy rate, and ovulation rate per cycle are higher with gonadotropins than CC. The last part, I think, of this fertility discussion would be laparoscopic ovarian drilling. I think there's one time when LOD was so common, maybe 10 years ago, where we used to do laparoscopic ovarian drilling right, left, and center for many patients. But over the last few years, it's almost gone out of vogue, and we hardly now do LOD for any of our patients. And it's all, if it doesn't respond to clomiphene or letrozole, you go on to gonadotropin and keep on stepping up the dose. At some point of time, you have to hand over to your fertility colleagues. So I think this is normally the things, not hardly they refer back to you to do laparoscopic ovarian drilling. That's far and few. And most of the times it's only medical management, and this has fallen out of vogue. Not that they were doing more holes and they were causing premature ovarian failure. That was one part of it. But the other part of it, if there is some, if there are two interventions which work the both way, one involves a surgery and one doesn't involve a surgery, I think that in the doctor's interest and the patient's interest, it's better that we do the one which does not involve surgery. And I think that's the thing. Cycle monitoring with drug costs coupled with multiple injections will influence the choice of gonadotropin. So whether you want to give FSH, whether you want to give HMG, whether you want to give recombinant, whether you want to get, it always is subjective to various trials and various things, and we're not going to those details. In the absolute absence of an absolute indication for IVF ICSI, IVF offered in PCO first line, it can be offered after the first and second line is therapies have failed and you've ruled out all other causes of subfertility. This is just one more thing about laparoscopic ovarian drilling. This is from the Cochrane database recently, that without medical ovulation induction may decrease the live birth rate in women with anovulative. So it doesn't increase, it actually decreases. So that is something which has come up in this review of several laparoscopic ovarian drilling. So moderate quality evidence show that it may reduce the number of multiple pregnancy, but it can also decrease the live birth rate in women with anovulative PCOS compared to medical ovulation induction treatment alone. So that means LOD is maybe more harmful than useful, is some of the such suggestions which are good. It may cause less OHS, less multiple pregnancy, but doesn't mean that you'll have more pregnancies doing a laparoscopic ovarian drilling vis-a-vis increasing your dose of gonadotropins. So the takeaway from this discussion is managing polycystic ovary across the life cycle involves several treatment approaches and incorporates different lines of management with a varying degree of evidence backing it. So that's a very strong, solid statement with a lot of things mixed together. But what we mean is that you need to update yourself with the current evidence, watch this space for emerging evidence on the different treatment modalities which keep on coming. So wonderful job done last 3 years by Dr. Rakhi Singh of the Clinical Endocrinology Committee, Reproductive Endocrinology Committee, and wonderful work ahead by Dr. Chaitanya, where there are a lot of focus on PCO. Under the supervision of Dr. Rishikesh Pai and Dr. Surekha, they have done this GCPR on polycystic ovary, which I was fortunate to have a small role there. And I think they've done a wonderful job. So if you have time and you want to have some more update on PCO, a good start point would be to go to the Foxy website and download the GCPR on polycystic ovary PCO there. A lot of effort has gone into making that. And all this extra guidelines, what we are saying, a lot of this has been taken into consideration, putting an Indian perspective to all of this. So the discussion on various facets of PCO will continue and intrigue reproductive endocrinologists of this generation and the next. So our discussion with polycystic ovary endometriosis is not going out anywhere soon, and we will continue speaking about this in our lifetime in different formats and in different settings. Now, this is what we are known now, and of course, it can change in the next few years, and we may be talking about something else. Thank you very much, Dr. Asha. It's been an absolute pleasure discussing these things.
Thank you, sir. Thanks a lot. You are a lifesaver at the moment because I'm getting messages from all my panelists. I'm traveling, I have to go to a wedding, I have an emergency. So you actually covered the topic. The basic purpose is to spread the knowledge and have some discussion. So if you can stay along for 10 minutes, all of you, we can have the discussion on the two cases that I have and we can finish with it.
Yeah, first we hear from our chairperson, Dr. Amrit, Dr. Amita.
Yeah.
Thank
Thank
you,
you, Dr. Mukherjee. Yeah, can I say?
Yeah. Okay.
So it is a very vast topic, and so beautifully you have covered each and every aspect of it. And PCOS really, they become chronic women like chronic PID. It never goes away. And you start COCs, the very point where we get stuck for how long to use. Like there's no point in using just for 3 months, minimum 6 months. And I prefer to use it for 9 months at least, and then see what is the response. You stop it again. Of course, their lifestyle modification, they are not very compliant, then it recurs. So again, the story goes on till they get married and you do ovulation induction. So that is one thing. And for metformin, like what minimum duration you recommend, sir?
Yeah, again, a good question. Nothing specific in the timelines. So 6 months, again, at least minimum, to see whether it's making a difference, especially when you're giving it alone without anything. You can give it for a longer duration of time. It's got minimal side effects, but at the same time, it will depend on what your objective goals are. If your goals are regularizing cycles and you've got it in 6 months, most of us would logically stop it for a few months to see how she's doing without it. So it's no point of continuing. Again, if pregnancy was the reason why you started it, once she gets pregnant, you stop it at some point of time. We don't stop it immediately, but possibly after 3 months. So those are the metformin goals.
Yes, and for obese, I think adolescents, we do give it for even longer time. Maximum you can give 2 years, and we see the good effects also.
Absolutely, that can be done.
So, Dr. Amrit, please. Thank you so much. It was very nice talk, and in such a short time, you have covered the complete subject.
Thank you.
Thank you so much, Dr. Basu, for the excellent lecture on PCOS management. And what I want to say, like you have already covered that lifestyle management is a lifelong approach. It's not that just saying to the patient once. So every time she comes, and we should go up to the level of the patient, like not only writing, but counsel them at their level, what is their need, and according to patient's need, individualized treatment each and every patient. Like if she needs infertility treatment, we have to go according to that. If her desire is only for the weight loss, regularization of the menstruation, so accordingly we will treat. One thing just I want to know, like about the OCPs, combination OCPs. If we, like the guidelines say that any of the OCP you can use low dose. If you use levonorgestrel and the ethinyl estradiol low at combination, is there any harmful effect or disadvantage than using drosperinol?
So, Dr. Amrit, let's leave the PCO aside and let us see that what do you do about first generation, second generation, third generation, and fourth generation OC pills. So each one of the progestins brings something to the table. So for the norethistron vis-a-vis drosperinone, the difference is your effect on the lipids, and the difference is your long-term effect on the liver. Little bit of the liver enzymes which are raised. So the more, it's not a question about they generally say that I think OCPs work in decreasing hyperandrogenism in 3-4 ways, of which most of them are common in across the progestins you use. But cyproterone and drosperinone bring a little bit more to the table as far as reducing the hyperandrogenism and the antimineralocorticoid activity is there. The long-term use is more safer than using a norethistron ethinyl estradiol combination for a longer time. So even if you keep the PCO aside, there are some concerns about your lipids, some concerns about your liver functions if it's given for a very long duration of time. So the commonest OCP in the world is the one with drosperinone, used in the Western world mainly because possibly it's more available there, or the marketing is done more in that direction. But that is the commonest used and one of the safest used. That is the reason why most trials are on drosperinone.
Thank you. One thing just I want to say, like we can motivate these patients by using smartwatches. Like every time you set a goal, if you do not get up after half an hour, there will be a message. So this is what I use practically. You have to walk, you have to do 30 minutes exercise daily. And it's very useful.
Yeah, and they keep on telling you in the watch actually. The watch by this time yesterday you did so much steps, now you haven't done, you're not making up. The same watch also tells you the Swiggy, are you hungry kya? And then where's your breakfast? You haven't ordered it last day. The same smartwatch will also tell you the same thing.
Yeah, that's a good motivation also. Every time it's for ourselves also, you have to get up, you have to move. You haven't done the work, you set a goal.
Move around.
Yeah.
It's quite a good motivation. Absolutely agree.
Yeah. And education and information to the patient.
The generation of they look at smartwatches and they look at digital things like never before. So that will be a big sort of a push thing to them. And they can always send it at the end of the day to the doctor and say that today I've done so much. Or they can form a group where everybody is motivated to lose weight. Everything can be done in a PCO club formation. Like you have your menopause clubs, you can have PCO clubs.
PCO club is good.
And then how everybody works towards motivating each other. I think that's where it works better than yourself. So there are definitely innovative ways, ma'am, as you rightly say, in which we can guide them, or they can even guide themselves, because the generation is very smart, Gen Z, so they can work on it.
And psychological aspects also. And so often we say in front of all of the other people, what is your weight and what is that? That should be not be like, like they are already overstressed, already suffering from anxiety, depression, and we are saying you are like more than 1 quintal and this and that. Sometimes we also do like the wrong thing.
Khate pite khandan.
Khate pite. Yeah.
That's another.
Poonam ma'am, would you like to add something? Poonam ma'am?
Yes, I'm listening to the conversation.
Yes,
So,
ma'am.
best idea is, I think, I agree with this, that help groups should be there. And the most crucial thing to be addressed is their psychological aspect, the body shaming, concerned about the future, because everything is so confusing. Nothing is, clear. Even the doctors are not clear what's going to happen. So the patient is also like in a dilemma that how long she has to pull along with the lifestyle management. So, it's easier said than done. To be very frank, you have to be in their shoes to realize what is happening to them. For us, it is easy to say that, okay, you start OCPs, continue this. And we have seen that young girls, like metformin, we also keep continuing. Sometimes we put them on metformin and they start normal menstruation. But I've noticed that once you stop it, maybe after 6 months, 9 months, you can't keep on giving it lifetime. So again, that cycle starts becoming the same. So then again, a lot of counseling is required for these girls, for adolescent PCOD. And infertility also, they have to undergo so much of, confusion. But I have seen that females, patients, they do conceive. Whatever is the severity of the PCOS, someday they do conceive. Sometimes with the normal ovulation induction, and even if it fails, after some time, you come to know that the patient can conceive spontaneously also. So it's just, they need just one cycle of ovulation. Sometimes the ovulation can occur spontaneously also after all these ovulation induction cycles. So, Basav, you have explained everything. And I feel the the recent guidelines, they are a little bit more clear than what we used to have earlier. And so many like extra investigations, they have already deleted those and made it very clear that letrozole is the first drug of choice and clomiphene is the second drug of choice. And we don't need to do so many tests for the androgens for the PCOS. So thank you so much. And thank you, Asha, for a lovely webinar. Thank you.
Thank you, ma'am.
Sir,
Yeah,
it's
nice
very,
meeting
it's,
all the
Dr. Asha,
chairpersons. I'm seeing them for
Yes,
the
ma'am.
first time.
what we see, it's very difficult to lose weight in these patients.
Ma'am, what about patients, about us when we try to lose weight?
We
When
are
you're
not,
trying to lose 1 kg yourself,
yeah.
it's tough.
These type, they have insulin resistance and they're difficult to for them, even if they are doing best of the
But
exercise.
sir, you said to stop metformin after 6 months or 1 year or 2 years. What happens if you continue with that? Does insulin resistance improve itself?
No, again, Dr. Asha, you have to understand that what you are doing is a correction for, means this is a lifetime disease. So this will go on as long as you're on. So anybody doesn't like to keep on taking medicines for any reason for a very long duration of time.
So liking is something else. But
Yeah,
does she need to take it? Because I have a friend, he's a cardiologist here, and he says that women who get cancer on metformin are the ones who get the cancer with low grade disease. Because somehow they have that, they have PCOS, they have a family tendency, but when they get the disease, it's lower grade. That's what he was saying. He works in AIMS here.
I don't know.
So
But
what is the harm if they just continue? That's what I'm asking you. If
but-
she is not saying stop, then do we have to stop or we can continue?
Again, the question is, why did you start it? If you said you're starting it for
For
regular,
insulin resistance. We started it for insulin resistance with her fasting insulin at the level of 125.
but again, they say that you don't need to do that for fasting insulin. And I mean, if you started it for diabetes,
Means you've done it and you've got it.
if you got
And
it,
then what?
pre-diabetes, let's say pre-diabetic, the 50% of the population is now pre-diabetic. So if you're starting it for pre-diabetic, then there's no point, then you can continue it for a long time. But the question, if you're starting it for irregular cycles, my justification, if your cycles become regular, you can always stop and see what happens without it. But if you started it because it's a pre-diabetic situation, again, as you say, the insulin, then you have no reason to stop it. Then you have to go, it's like low-dose aspirin for heart problems.
Yeah, so that is what I just wanted to make clear, that, if you have those high levels, then you really need to continue and you
Right.
don't stop.
Then you have also dietary modification and this, so you have a
Yeah.
diabetic diet and you work it up. And
Barwal sir, you're still there. Would you like to say something?
yeah, Arunda's hearing, I think. So he's seeing patients and he's also hearing. Weight loss, Arunda, your mantra of weight loss, if you can just say how.
Basically, what my mantra for my patients to weight loss is, you have to be together with the similar groups, get motivated, and reduce weight step by step. If you give them a big target, you will never succeed. You have to give them a small target. Give them a target of 1 to 2 kg in 1 month. Everybody will be happy to achieve their target. Just like the all electronic watches that we were all talking about. You set your own move goal. Once you achieve the move goal, there will be a lot of appreciation in the electronic media itself. So you
Right.
feel little elated. So
Yeah.
you need to keep that elevated mood going in this patient. Otherwise, they will never be able to lose weight. So you call them for consultations frequently, stimulate them, ask them to reduce further 1 to 2 kilo. And we all know reducing 5 kilo is enough to achieve the fertility. So the 5% is not a big deal. Deal is when you have to tackle with a metabolic correction. I think that requires a huge motivation and a continuous therapeutic approach, so and so that patient really feels at home.
Yeah, can I add?
That's how.
Yes, ma'am.
Yeah. I think Dr. Basha did mention the underlying depression. Now, whether depression precedes them or the PCOS precedes it, it is not very well known. But if we go into the detailed history, many times they do require psychiatric consultation and antidepressants. And if they are depressed, that is, they eat more, their inactivity is more, so weight gain is more, and losing weight is less unless we identify underlying depression in them. So
Meeting them frequently and giving them a word of encouragement is more important. I think that is why set small targets. Let them achieve it faster. They will also feel happy.
Yes.
Sir, I have a patient. She was 87 kilograms and she had severe PCOS. And she was like 23 years old. Over 1 year, she joined the gym and she's come down to 65 kilograms.
Yes,
but her
that is
PCOS has not improved. It has not improved. You stop the medicine, she doesn't menstruate.
Okay, so her diagnosis needs to be relooked at probably. What I would have done is, she will not really fit into the classical PCOS. We'll have to see for the other causes of irregular periods as well.
So what would you look at?
Definitely, I would like to look at adult onset congenital hyperplasia. That is one of the most common things. Maybe some form of what I would say decreased ovarian reserve as well, which post-COVID, we have started seeing more number of patients who have actually lost their ovarian reserve. That is one set of
No, sir, her AMH is still above 9. Her AMH is still above 9. And her cycles will not come by themselves. If they come over 3, 4, 5, 6 months, then she won't stop bleeding. And she is 5 feet 8 inches at 65 kg. She looks beautiful.
Yes.
So
I'd like
now
to,
because she
I would
isn't
like to
getting
see
well,
the LH of the patient. LH on day 2, I'd like to see on that particular patient.
Yes, LH is raised. FSH LH ratio is reversed.
Definitely, she would require some hormonal correction in that particular system.
We are giving her OC pills. That's what I said. I started with combined pill. And then after some time, means we did it for actually a year. Then we stopped. Then I kept her on only 10 days of progesterone every month. Then I stopped. And once you stop, it's back to the same story.
Then I'll go by the concept of PC Mahapatra. Lucky patient, lucky doctor, good result. Unlucky patient, unlucky doctor, worst result. Unlucky patient, lucky doctor, and vice versa, mixed results. That's the only thing. That's medical science.
Yeah, she will need even longitudinal survey. She might be hypothyroid later on. So
she is hypothyroid. She's on 175 milligram.
That
Now
is
she
the
has covert diabetes. She has been diagnosed with schizophrenia as well. So
yes.
I
all
am
these things.
actually stuck what to do now.
She has to be on medication. That's it.
Basab sir, any comments?
Have you added metformin to her?
Yes, she is on metformin 1 gram BD.
I think, Dr. Asha, we always have from time to time have few people which is difficult to, which doesn't go into conventional wisdom. So that's what I think. I think what Dr. Arun said also, you need to revise the diagnosis of PCO. Just make sure it is PCO and not anything else.
No, so what else? What else do I test her for?
No, she's having treatment for schizophrenia also. Those cause hyperprolactinemia and amenorrhea. Her
Ma'am,
periods
she
can come
is
down.
not taking treatment for schizophrenia.
But
She
still
has
it
to
She
take,
had a
ma'am.
frank paranoid syndrome. She shut herself in the room. Her father brought her to me, but she refused to go for psychiatric treatment. The father said, "Shadi karne se theek ho jayega." So, see,
See, menstrual cycle is such a sensitive thing that if she is under so much of stress and she has mental problem, that will affect her menstruation, not only PCOS.
Yeah. That stress factor has to be, ma'am. The psychiatric treatment has to be done.
yeah, but see,
Yeah.
here in our country, you know the stigma that psychiatric treatment has.
I know,
Counseling,
unless
counseling
that
and
way,
Done.
all the
Just doing it
endorphins and
still.
the metabolites in the brain, they control menstruation, and that has to be
Yes.
counseled. Yeah.
Yes, ma'am. Dr. Basab, any comments?
No smart answers to your problem.
Yeah.
Dr. Chaitanya, if you are still there, would you like to say something? Dr. Koshi?
Good evening, ma'am. I would like to stress on the long-term effects of PCOS, especially the perimenopausal PCO. Often we neglect them. Once the infertility issue is over, PCO is also over. That's the usual thinking. But going to the long-term effects like the high risk for cardiovascular disease, lipid disorders, then high risk for cancers. Everything has to be educated to the PCO patients so that they will take care and take preventive measures to prevent all these long-term effects so that they can gracefully enter the menopausal stage and have a menopausal life which needs no support from other persons. And
thank you.
This can and maintaining a good body weight and maintaining good exercise will improve the bone health also, so that she will be in her old age she will be fine with her activities. So my question was whether metformin should be continued in such patients who are at high risk for continuing with bad effects of perimenopausal PCOS.
Basab sir, that's for you.
That was also already answered.
Yeah.
Long-term use of metformin.
So she's asking, in perimenopause, should you continue with metformin?
So again, perimenopause is a very tricky time. So you need to know that it's a PCO which is going on. So whenever it's near after 45 or near 45, you'll think about your hypothalamo-pituitary axis playing the tricks, and that's the reason why the irregular periods are happening. If she has a background history of PCO, some amount of type 2 diabetes by that time, yes, mind. If it's a type 2 diabetes, she may already be on some anti-diabetics. So metformin may not be of value out there. But at the same time, you need to make sure that the cycles are regular. Endometrial hyperplasia is a concern. If she has long irregular cycles, I think those need to be addressed. So possibly instead of metformin, some sort of a low dose OCP would be of more value at that time. So it all depends on the setting which is there. It depends on the age in when the problem is. 40 to 45, you still can have metformin, but at the 45 plus, very likely that she's having a irregular bleeding, and that may not be related to your PCO. But needless to that, You can't allow her long periods of amenorrhea. That needs to be settled with some sort of a medication, which usually will be hormonal and less likely to be medical.
So, Nija ma'am, you are so much of a onco person. So, what would you suggest for preventing cancer in such women? You know, she is high risk, she has PCOS, she's had it since teenage. So, what would you suggest that she should take? You know, you should advise that patient to prevent. And if she has that heavy episode, would you give her hormones without doing an endometrial biopsy?
You were asking me?
Yes, ma'am.
Yeah.
You are an expert.
Okay. So her cycles have to be regular. If she is PCOS, they do develop endometrial hyperplasia and early onset endometrial CA. So, if it is a very frequent problem and she's having heavy bleeding followed by, preceded by amenorrhea, and it is not responding to hormonal treatment. Sometimes, despite giving hemostatic doses of progesterone, their bleeding doesn't get controlled. Then early EB should be done to rule out endometrial CM or the hyperplasia. So that is one message. And to prevent cancer, we have to really give progesterones. As Dr. Bashik did mention, that 8 cycles a year they should have minimum to have the endometrium shedding. That will go a long way in preventing cancer. Metformin is anti-cancer drug, but still now we can't use it as anti-cancer drug. Okay, there is some evidence that it has anti-cancer properties, but whether it can prevent endometrial CA, we really don't have any evidence.
Okay. So I think we are done for the evening. Dr. Sadhna Sinha ma'am, aap aa gayi hain. You want to ask something?
And one thing,
Sadhna
can
ma'am?
I add, Dr. Asha? Like for
Yes,
adolescent
ma'am.
PCOS, one should not label it too early. They do have very
Exactly.
commonly irregular cycles. They are obese sometimes, and PCOM on ultrasound is very common. So only on basis of hirsutism, hyperandrogenism, which can be clinical or it can be, biochemical. So keep them under longitudinal survey. You can start
Yes.
OCP if they have abnormal menstrual cycle. So treatment can be started, but don't label them PCOS. I get so many references because when it is their matrimonial time, the boys' side, they'll keep asking me, she's having PCOS, can that girl is, we should go for marriage or not? So labeling PCOS, it's a metabolic syndrome, lifelong diagnosis. So we should not label too early, keep them under longitudinal survey, whether she fits into the definition of PCOS or not. And treatment can be started even without the diagnosis of PCOS. That's one
Thank you
message.
so much, ma'am. That was a very precious point because we had a meeting in our society couple of days back, and they said the incidence of PCOS now is between 36 to 50%. Now, if every second person walking into your OPD by any one thing, she's missed one cycle in her entire life, and you label her PCOS based on that ovarian morphology. So I think the one takeaway from this session should be that make your diagnosis wisely. As Dr. Chaitanya has said, the assessment, that is why we kept that as a separate topic. That assess correctly. Don't label everybody as PCOS.
Man,
Yes,
excuse
Dr.
me,
Sadhna?
madam. There's one
Yes,
question,
ma'am.
madam. We get patient of PCOS of having continuous amenorrhea. When patient comes, we give for withdrawal bleeding, we give progesterone. She menstruates, and again, we just tell her to reduce weight and all those lifestyle changes we advise. But still, the patient is suffering from amenorrhea, and we are also fed up how to treat this. Madam, please tell us something about it.
That
When
has
she's
been
on
discussed. You have joined late, that how to really made her compliant for weight loss. And then you must also look what is the other cause of amenorrhea. Once we label her PCOS, we can't say she's amenorrheic just because of PCOS. Try to rule out congenital adrenal hyperplasia, adult onset. Try to rule out hypothyroidism or hyperprolactinemia. And then we have to give, if we are giving OCPs, give them for minimum 9 months. Don't just give it for 3 months and then break it. So continuously counsel them that this problem can recur. So you take it for 9 months, we'll give you a holiday, and then we'll see how your menstrual cycle behaves. Meanwhile, you do the lifestyle modification, and that will go in long way. So counseling, and then treating her properly with the duration, and then again counseling, and add metformin if you require.
Yes. Thank you, madam. We never gave for continuous for 9 months. Now we'll try with continuous 9 months. We used to give for 3 months.
And metformin also minimum you would give for 6 months, and can be
metformin.
given for 2 years continuously, and right dose. Giving one tablet will not suffice. So we can go up to 2 grams, but 1 TDS slowly increasing is the right dose, and they do respond.
Thank you,
Dr.
madam.
Neelam? Dr. Neelam Sinha, you want to add something? No. Yes, sir. Barua, sir. Bye. Okay. Thanks a lot. Thank you. Thank you, Suneja ma'am.
Yeah,
Barua,
thank you
sir.
so much. I'm also
I hope you enjoyed the session.
Yeah, yeah.
Yes, yes.
Okay.
Thank you, Dr. Chaitanya, Amrit ma'am, Dr. Dr. Thingu Thomas Koshi, and Dr. Basa Mukherjee, who made so much of an effort and made the program really good. Thank you.
Dr. Thank you very much. Thank you.
Thank you, Corona, for being our academic partner. And please do help me for nomination for chairperson, Food, Drug and Medico-Surgical Committee. Thank you. Thank you very much. Hope to see you in another webinar soon.